Hi, I'm Drake.
I'm Rita.
I'm Anita.
And I'm Carly Bess, and we are health policy and management students at the Gilling School of Global Public Health. As seniors, we will be completing a capstone project with UNC Healthcare, which will assess the feasibility of implementing a telepsychiatry program in their emergency department. Before diving deep into this project, we decided to explore telehealth by interviewing key stakeholders: a patient, provider, health insurance representative, and the co-founder of a telehealth platform. By conducting these interviews, we hoped to gain a holistic understanding of telehealth.
To begin, what is telehealth? It's a modern form of healthcare delivery that uses communication technology to promote long-distance health services and education. It leverages the accelerated adoption of mobile technologies in clinic and home settings to address pressing health issues, expanding access to services, and improving patient outcomes. It was initially adopted to expand specialist care to areas with a lack of specialist providers, but it is steadily becoming a mainstream modality of healthcare delivery for communities in remote areas. Its broad applications include live video conferencing between patients and physicians, mobile health communication, and remote patient monitoring. Its broad applications include live video conferencing between patients and physicians, mobile communications, and remote patient monitoring. So, why is this important?
Well, telehealth services have been shown to alleviate issues of provider shortages and access to care in rural areas while maintaining or improving health outcomes. Despite the benefits for patients, there are other stakeholders involved that have different perspectives on telehealth. Since none of us have used it, we wanted to know what it actually looks like and some of the issues surrounding it. Since telehealth has a broad definition, visits using the technology will vary significantly, but we talked to a patient who decided to remain anonymous to gain a better understanding of her experience.
I used it for a geneticist in Atlanta who specializes in a metabolic disease that I have, and you can look up her practice. It's called virtual medicine practice, because I think she was a pioneer of doing this kind of thing, and so she just named it a long time ago. So she literally just Skypes with you. We did some Skype. She had to sign a waiver, and then also she would do some phone calls. She had me go in for one in-person visit first, because for her to be able to prescribe anything, she had to have one in-person visit. But then other than that, she was like, I've already examined you. There's really no reason for you to have to travel. So
a telehealth service could be as simple as Skyping with your doctor, but despite the flexibility of Skype, she did notice some limitations.
The only hard part about the telemedicine was kind of when I got the formal diagnosis, I was with my family, but it is so different having a doctor who's on Skype, and it was a hard diagnosis, and my mom was getting emotional, and it was just really weird to not be in a room with the doctor. On some level. It was much better than having to fly to Atlanta to get bad news and then fly back, but it was still definitely having it on Skype was a different interpersonal element. Yeah.
Obviously, this was hard for her. Lacking that interpersonal element can be difficult in a provider-patient relationship.
To get a sense of what these encounters look like from the provider's perspective, we talked to Dr. Sai Saeed, Chair of the ECU Brody School of Medicine Department of Psychiatry and Director of the North Carolina Statewide Telepsychiatry Program.
So patient, once they show up at the ED because they are in a mental health crisis and they need help, they are first seen by an ED physician who determines that yes, a psychiatric consult is needed. So at that point, the ED staff would basically inform the patient that this will be a visit that would come through the screen via telepsychiatry interactive. It would be just like any face-to-face encounter, with the exception that the provider is coming technologically or virtually. At the same time, the hospital would log into a web portal that we use for this. The purpose of a web portal is to exchange information. What that means is that in essence, when I'm seeing a patient face to face, I log into a chart and I look at what labs have been done, what other studies may have been done, why is the patient being referred, what medication the patient may be on. And once I see the patient, then I'll write a note in this so that the whole treatment team is aware of that. So all of this is being done through the web portal. So the patient gets a schedule to be seen by our psychiatrist. That psychiatrist, who is remote, will receive a prompt on their screen saying that there's a patient in the virtual waiting room to see. The psychiatrist would log into the chart, would review all the labs, and why is the patient being referred. At the same time, in the ED, the nurse is informing the patient about how the visit will take place. And they roll in this telepsych card, which is a screen as well as all the built-in HIPAA-compliant equipment to make sure that there's some encrypted information that's going across the lines. And then the psychiatrist comes live, and basically a conversation and examination takes place, just like it would face-to-face. Patient can interact with the doctor, and doctor interacts with the patient. By the way, these cards have the ability to even listen to patient's heart if that's needed, listen to their eardrums, and do even a physical exam.
With all of these moving parts, how do you see it impacting the provider-patient relationship?
People just don't like the idea of talking to their provider on the screen. Although that seems to have changed quite a bit. So time after time, all of the surveys of consumers that have been done, there seems to be really not as much of a resistance on part of the patient.
Looking beyond the provider-patient relationship into a system level, does telemedicine increase access? Ben London co-founded a maternal health app, Pacify, to address access problems he saw as a consultant.
We call it a telehealth platform. It's what I often call a vertically specialized telehealth company, which is to say we are specifically focused on the maternal and child health space, and what we have is a platform that allows new families to access nationwide networks of nurses, lactation consultants, dietitians, anyone who can help them during or after a pregnancy immediately, 24/7 on their smartphone. We both worked in healthcare. He was working in Medicaid. I was working as a strategy consultant for hospitals, and we were looking at the same trends. He saw huge cost overruns around pregnancy, just the enormous cost of pregnancies, particularly when we end up dealing with when we have prematurity, NICU stays, outcomes that we don't want. And I was looking at emergency rooms and realizing that in the data in most emergency rooms in the country, you see an enormous portion of visits that are families that don't need to be in an emergency room. They're there for non-urgent reasons. They're there because they didn't have access to any other options. They're there because they couldn't afford other options. And we started brainstorming around there's all of these new telemedicine companies out there, the doctor on demands of the world, the teledocs of the world. What would it look like to build a version of that was targeted at this particular problem? And so we started brainstorming. We realized pretty much right out of the gate that if you want it to be affordable in the public health space or in Medicaid that it needs to use, that using doctors is really expensive. So could we do it with physician extenders? Could we borrow ideas from other innovative companies like Uber around how to source the first available clinician in different circumstances? And a year later, we had Pacify.
Another major player in any telehealth service is the payer, which reimburses physicians for conducting telehealth services. Many payers across the industry have recognized the impact telehealth has had on increasing access to healthcare. We talked to Molly O'Toole, the Director of Medical and Reimbursement Policy at Blue Cross Blue Shield of North Carolina, about how access has been improved across the state.
I'll say this. We have partners with Biden that are out of East Carolina, and they have a very robust telehealth program, and they feel like they've had excellent success with their program because in the eastern part of the state, there are a lot of accessibility issues, and several smaller hospitals closed that had once served, rural populations. And so I think all of our larger facilities that are partners with across the Shield, I think East Carolina has um, really done a great job utilizing telehealth and improving the health of our members in the eastern part of the state.
She also believes that mental health is one of the best issues to address through telehealth.
Those are perfect services for telemedicine because you don't have to have that face-to-face interaction where you're sitting in the same room. And secondly, behavioral health, people who have issues with mental health or substance abuse or those kind of things, they need a lot of interaction, and that's just not convenient to be done in an office setting. So being able to do that through telehealth is perfect. And as a clinician, I would say that telehealth is very well suited in the mental health arena. Utilizing telehealth for behavioral health services is an excellent way to use telehealth. I really do. Of all of the medical services that can be performed using telehealth technology, behavioral health is number one, if you ask me.
Dr. Saeed has been leading efforts to expand telepsychiatry services across North Carolina. He gives us an example of the power of this technology.
Telemedicine is used mostly in situations when access to care is a problem. So to provide the backdrop for this, what we have here is that we have psychiatric disorders, which are very common. So at any given time, 1 in 4 people may have a diagnosable psychiatric illness. So that's a very broad net. But even if you limit it to the severe and the most persistent and chronic mental illness, we are looking at roughly about 7% of the population. So these are the people who need care on a routine basis, usually care that includes medications and seeing a specialist, namely psychiatrist in this case. So that's one area that these disorders are common. But when you look at people who are available to provide this care, there is a nationwide shortage of psychiatrists as well as other mental health professionals. So with those two things put together, what you got is a significant access problem. So pick any state, and if you just set aside the 2 or 3 big metropolis areas in those states, everybody else comes out short. So, for example, in North Carolina, basically we have at this time about 56 of the counties of 100 that are considered mental health shortage area. We have 31 counties out of 100 that have no psychiatrists available. So what do you do in that case to bring care to people or provide relief of this problem? So that Ocracoke is one of the barrier islands. So to go there from Greenville, North Carolina, you have to first drive to the ferry terminal, which is about a 2-hour drive, and then you get on the ferry to get to Ocracoke Island. So whether it's a patient coming to Greenville or the provider from Greenville going there, but either way, it's a full-day event for a visit, which may be just for an hour. And when you use telehealth, teleflight for that, you make it a whole lot more convenient for the patient. And you provide the provider a lot more option to see more patients. So, for example, if I get in the ferry and go to Ocracoke, I would barely have enough time to see 2 patients by the time I get to Ocracoke, because otherwise, if I miss the last ferry, I'll have to stay overnight. On the other hand, if I do that by telehealth, I can see as many as 16 to 20 patients.
Although behavioral health is one of the most common issues addressed through telehealth, its use has been expanding to support patients with a variety of health needs. Our patient describes her experience in accessing medical care for a rare genetic disease.
I have a condition called mitochondrial disease that really there's only kind of maybe 10 doctors across the country that, like, there's other doctors that, like, see some patients, but there's probably 10 that are just, like, the super major specialists in it. So, but of course, lots of them are not taking new patients at any given time. So really my other option was to go to Ohio. Yeah, no, like I've been honestly all over the country for medical care. It definitely is, of course, never convenient to be traveling that far for medical care. But she's very much an expert in it. So I went to her for diagnosis because it's kind of a complicated disease to diagnose. So it was worth it, but definitely we chose her because then I didn't have to go back for follow-up visits, where if it was another doctor, like I would have had to travel, and then I would have had to travel again for follow-up. When you get to like talking about like really rare conditions, it's like maybe if you're in like Boston or whatever, like you can probably find a doctor, but it's like we have so many major like I'm from Chapel Hill, like we have like major medical centers there, but it's like when you're talking about like 10 doctors in the country, really most people are not going to be anywhere near them. So I think telemedicine was just like so helpful. I think it was really helpful at kind of making sure I was able to get a firm diagnosis from like a world expert without having to like travel a bunch of times. And if there hadn't been telemedicine, I don't quite know that my family maybe wouldn't have gone through it if we knew that we were going to have to travel to Atlanta like for multiple visits. And so like I think it definitely has been really good to make sure that I ruled everything out. And I know other people that have seen this doctor who they live close to geneticists, but they're sick enough that it just makes more sense for them to see a telemedicine geneticist across the country than kind of go, because like genetics, like even if you're like maybe a couple hours away, like it's easier to, or even some folks that are really sick, like even if it's just in town, it's so much easier to just like call the doctor.
Despite the benefits we've been talking about, current reimbursement policy around telehealth services is complicated and has resulted in multiple barriers to adoption. Medicare restricts telehealth reimbursement to certain types of facilities, making it difficult for providers to make it financially viable. Medicaid reimbursement varies significantly by state, but again, it is often too low to make the services financially viable for providers. Additionally, only half of states have telehealth parity laws, meaning private payers are not legally obligated to reimburse telehealth services at the same level as in-person services. But some do. BCBS has been reimbursing for telehealth services since 1997, according to Molly O'Toole.
The use of some of the national players for telehealth, MD Live is now offered. We cover MD Live services for our commercial membership and for many of our large employer groups, so that if one of our members, has an issue that they think could be addressed through MD Live or Teledoc, then we would cover those services. That would be part of our members' benefit. What we don't cover is the same provider on the same day. So let's say the brick and mortar provider has telehealth capability. The member calls the doctor and says, I've got this infection. What do you think? And they have a conversation, and the provider then says, come to my office and I will see you. Well, that provider can't bill for both services.
How would you describe the payer-provider relationship in regard to telehealth?
Well, I mean, if you were to ask the provider community what Blue Cross and Blue Shield and any payer could do better, and they would say parity. They would say, pay us the same amount of money for a visit, what we call an E&M service, evaluation and management. E&M services are your office visits. Pay us the same for a face-to-face office visit as a telehealth visit, and we'll jump on this and do more of it. when you're in the fee-for-service world, which we're trying to move away from, but when you're in the fee-for-service world and the provider sees the patient, they send in a claim or an office visit, an E&M service visit, and we reimburse them for it. And then there's a cost share, the member pays $10 or whatever their cost share is. That's fee-for-service. Well, those fees are set on three different things: the work, the intensity of the service, and the overhead. So theoretically, if you're providing telehealth, your overhead is dramatically decreased. So we wouldn't pay as much. In other words, you don't have to have a receptionist to check the person in. You don't have to have a nurse to put them in the room. You don't have to provide the gown. You don't have to provide the office setting. There's a lot of overhead that's eliminated by using telehealth. That's been, as we move toward value-based reimbursement, in other words, we'll pay you for our member a certain amount of money, and we're going to pay you for the quality of services that you provide and how well you take care of our members, and we're not going to pay you for you're not going to nickel and dime us for every little claim, every little service. Once we start moving to a different payment methodology, I think then they will find telehealth to be very helpful in keeping their costs down. And these providers bring their costs down, but their quality goes up because they're able to spend more time with our members through telehealth, let's say, and they get enhanced reimbursement because they're providing good quality service. That's when I think telehealth is really going to take off.
What's interesting was that not all payers are equal. Molly tells us that Medicare has a more restricting reimbursement policy than commercial payers.
I'll tell you what really has hampered our Medicare Advantage membership for this is that CMS requirements are much tighter for these services than for our commercial policy. In other words, for our members, they can be in their home and receive telehealth services, and our providers can bill for them. In CMS, they have to have an origination site. So in other words, the member can't be in their house. They can't be in their home. They have to be in an office. They have to be in an emergency room, a clinic, some sort of health place of service, healthcare place of service, as an origination site before they can receive telehealth services. So basically what CMS has done is limit these services to specialty, really.
While reimbursement for Medicare Advantage members can be complex, other government payers have successfully partnered with companies like Pacify. Ben London expanded on the relationship they've built with state Medicaid and WIC programs.
Once you can make it available at an affordable price point, those organizations become your biggest supporters and your best clients. We have been working with WIC now for many years in many different states to support their new mom population and their pregnant population. We're now working with Medicaid at scale. We're working with some of the largest Medicaid companies in the country to support their pregnant populations. And so one of the neat things is that you, once you can solve that equation and create a product that's actually affordable and accessible, all of a sudden you realize that there is this tremendous demand out there in these populations that have been largely overlooked in the past.
While payers and intermediaries point to reimbursement policies as key to telehealth adoption, providers have identified other unique obstacles, including licensing and credentialing, that play into this complexity.
So the healthcare is taking place where the patient is. So if the patient is in, for example, North Carolina, and the provider is seeing this patient from Maryland, then the Maryland provider would have to be licensed in North Carolina, because that's where the healthcare is taking place. So what that means is that if there is a group of providers in one state, but they are seeing patients in several different states, they would have to maintain those licenses in all of those states. Related to having the license is also a question about credentialing. So if the patient is being seen in a hospital, that provider would have to be credentialed in that hospital, because basically credentialing is the process by which a hospital or healthcare institution will determine if the provider has the right credentials, has the right skill level, and is competent to provide the care that they are providing in their facility. The difficulty in this area from day to day running of a telepsychiatry program is that when you provide care in multiple hospitals or multiple states, you have to do a lot and lots of this paperwork and pay dues to maintain all of those privileges and licenses.
All these administrative and reimbursement complexities seem to be a barrier for providers and hospital systems. So how did our patient experience these hurdles?
That is an excellent question, and definitely I should have thought of that as a downside. So the doctor, the way she does it, which I kind of have complicated feelings about, is that she just charges you out of pocket and gives you paperwork to submit to your insurance to get reimbursed for however much you can. So my insurance was really good, and we were able to get most of it covered. But of course that was my parents had to front the money, and insurance would reimburse after the fact, which a lot of people can't do.
Yeah.
And I think she charged slightly more than the insurance reimbursement, so there was a bit extra that my family had to pay. I assume that many insurances are not nearly as accommodating as mine was. She clearly was just fed up with having to fight insurance all the time to get telemedicine covered, and so kind of outsourced it to the patient. She, I think, provided us with some materials to help us argue it with the insurance. I think the telemedicine aspect they were fine with. There was the bigger issue with, I think we eventually were able to get her compensated as in-network, because we argued that there wasn't an expert that was in-network, and she helped us do that. But I think they were all right with the telemedicine aspect.
Although her experience is not ideal, the fact that her insurer was willing to pay for these services speaks to the growing acceptance around telehealth as a mainstream modality of care.
Despite telehealth's challenges, its use has been embraced by many patients, providers, and payers alike. So, what does the future of telehealth look like? How do key stakeholders expect this landscape to change?
I think that our providers are going to push for parity. They may actually try to go to our legislature and see if they can ask for these types of mandates and require the telehealth as there. As we move from a fee-for-service payment methodology to value-based payment to our providers, I think that they will find telehealth to be much more useful and will support their being able to meet their quality metrics that we're going to have set up to say, if you meet these quality metrics, we're going to pay you an incentive, or we'll be and value-based methodology and payment methodology becomes more robust, more mature, maybe. I do think providers see the advantage of telehealth and will decide that this is my office needs to purchase and utilize so that we can provide this quality care to across members. And I think that's what's going to make a big difference.
Telehealth in many ways is the future.